This is the lecture for intravenous therapy and delivery systems and equipment from Chapter 12 of your Horntvedt book. This will go along with the quiz in week 2 that you will take during lab, which is a proctored quiz. Normally, the Horntvedt book always has a math quiz, but this week it's still a proctored quiz you'll take in lab. However, it is over the content in Chapter 12, which is over IV delivery systems. And so it won't be a math quiz this week in lab that you'll be taking. I also have some information in this PowerPoint from your ATI Fundamentals of Nursing book, the 9th edition, and I'm using pages 289 to 294. I have copy and pasted the objectives from Horntvedt Chapter 12. They're found on page 203. So let's talk a little bit about IV therapy. We use IV therapy for many different things in healthcare, and basically IV therapy or intravenous therapy just means that we're giving some type of a fluid directly into the patient's circulatory system. And so sometimes we'll use fluids just to correct a nutritional imbalance or an electrolyte imbalance. Sometimes we'll use it just to give them extra fluids if they're dehydrated, and other times we'll use this to administer medications. The main thing that we need to keep in mind at all times when we're talking about IV therapy is that when we give the medication via the IV route, it's very, very rapid. That medication is immediately dispersed throughout the whole body system, and so there's not time to double think your dose or anything like that. You've got to make sure that what you're giving is the correct medication, the right dose, and you've got the right client, because major errors can occur if all of those things are not happening. When we look at advantages and disadvantages to IV therapy, there's some good advantages. It's really nice when you can give a client medication if they're having pain and they have an instant relief of that pain. If we're giving a medication such as morphine for pain, the client will have immediate pain relief, or they should have quite immediate pain relief. And so usually we'll come back and check on those clients within 10 minutes and they'll have some relief from pain. Whereas if we gave an oral medication for pain, oftentimes we don't see that start to work until about a half hour or an hour. When we have a client that's on a continuous infusion, I think of this with labor and delivery a lot when we give magnesium sulfate infusions for moms that are either preeclamptic or have preterm labor symptoms. They have a constant therapeutic blood level of that medication. So we can't do that with oral medications, and we also can't do that if we use injections via the IM or sub-Q routes as well. So we can give a medication and we can set our IV pump for so many milliliters, and we can rest assured that that client is getting that continuous, constant infusion of that medication. If you think of a client that needed something, an example would be Toradol. We give a lot of times after surgery. We'll give it every 6 hours for pain relief. And if we were going to give Toradol and we didn't have an IV to give it, we would be giving that client an IM injection every 6 hours. And so you think of what that would do to the subcutaneous or the muscle tissue, whichever route you give it, to be constantly giving that client injections. So the IV is such a nice route that we have in practice in the acute settings most often, so that we can quickly, easily, and efficiently give medications to our clients. There are, however, some disadvantages that do go along with this route. If the nurse is not very astute to the rate of medication, you can very easily give your client a fluid bolus and overload them. And so if you needed to give fluids via a gravity route, which we're going to be talking about later in this presentation, and you didn't have your drip rate calculated right, or you didn't have your roller clamp set right, you could accidentally give your client a whole liter of fluid, and if you weren't in there checking on them, they could have circulatory overload then. We also talked about how it's an immediate absorption of the medication or the fluid that's given. So if we push too much Latex IV, we can't, induce vomiting or some of the other things where maybe you would have a little bit of time to think about how you could counteract if you were giving it via the oral route. And so very immediate reaction to what we give. Sometimes medications will be harmful to the vein and they'll cause a little bit of pain or redness, and so that can be an irritation or a problem for some clients. And then if we don't clean properly before we insert the IV, if we don't clean the hub properly before we inject medications or use sterile technique and implement asepsis when we prepare the IV medications, we can cause really, really horrible infections to our clients. So those are some of the main advantages and disadvantages that I think of when I think of IV therapy. There's different types of fluid categories that we may give a client, and sometimes we'll give maintenance fluids. And these will be if maybe a client has not been eating, they are NPO because maybe they have a bowel obstruction. And so we would give them maintenance fluids, and that's just to make sure that they don't become dehydrated. We'll also use these sometimes to replenish an imbalance of some sort that we see based on laboratory analysis. Also, we may give replacement fluids, and so sometimes we'll give replacement fluids if a client came in and I think of burns oftentimes with this, or if they've been sick for a couple of days with GI flu and maybe they've had diarrhea or vomiting, and so replacement fluids oftentimes are given, and it's just a certain amount. Maybe they'll just order 1 liter to be given over X amount of hours. Whereas sometimes maintenance fluids are given and it's kind of in order such as 125 milliliters per hour, and there's no end time, and it's just kind of a continuous order until the provider would order to stop those fluids. When we look at the IV catheter, I want to talk a little bit about what happens when we put an IV into a client, because sometimes you'll hear clients say, well, this needle that's in my arm is really bothering me, and there's some misconceptions when we come to looking at the IV and what the IV is. And so what we're actually inserting into the client's vein is this needle right here. And so it's a needle that initially pierces the skin, but then you're going to learn in lab next week, you need to continue to push the IV in after you see flashback in the chamber. So once you hit the vein, you're going to see blood. It's going to go through this area. The reason we need to continue to push the catheter in a little bit more is because we need this part to get fully into the vein. If you pull the needle back out at this point, this won't be in the catheter or into the vein yet, and then you will have essentially you'll need to start or repoke the client again for a new IV site. So we put this needle in. The needle is covered kind of by a straw. I usually tell clients we're going to leave a flexible little straw in your vein, and that'll move and that'll help us to give you medications. When I say move, you know, if it was on a part of the body where there needed to be bending, it's a flexible straw. And so we don't leave that needle in the vein. We pull that needle back out after we've pushed and ensured that this catheter is well into the vein. And so we've got that hollow plastic catheter, and we're going to talk a little bit about sizes coming up, but there's different sizes. So when we talk about a certain gauge, that would be the size of the IV that we are inserting. And then what we do is we take out that needle and we leave that plastic stylet in. Sometimes, especially in rural areas, you may in the ER see a butterfly set used. If they're in the field and a paramedic or an EMT puts in an IV, sometimes it'll be a butterfly set, and it's just basically a needle, and in those cases the needle is just in the arm. We don't use these in acute care settings unless it's a dire circumstance and there's no other way to gain IV access, but I haven't honestly ever seen them used in an acute care setting. Sometimes this is what clients will come in with, and then from the ambulance, and then we'll put in a regular peripheral catheter. So when we look at catheter sizes, we are identifying them by gauges. So here at the bottom, you can see that there's some different gauge numbers, and it's the opposite of how our mind sometimes thinks. So a very, very teeny small catheter, which we select, and what I use for when we put them in babies, would be a 24 gauge. You can see here that it's very small, and it's just not as wide. When you would have a client, maybe a huge trauma that comes in, and you're just going to need to give massive amounts of fluid and blood. A 14 gauge is the largest that we have available at most sites. When you look at an 18, standardized, the color is standardized across the board, and so you can look at the hub of the IV that your client has, and without even knowing what size the nurse put in, you would know that green means 18 gauge. And so a lot of times for surgery, we'll put in an 18. I always put 18s in labor and delivery clients because you never know if they're going to need a rapid administration of fluid for surgery or anesthesia, and then also for blood or blood products. But a lot of times if a client's just on the medical or surgical floor, you may see a 20 or a 22 gauge in practice most commonly. So you just need to know that their gauge number gets larger as the diameter gets smaller. There's also a length on IVs, and you can see this IV here is not as long as this catheter is, and so there's not only a diameter, which is represented with a gauge number, but there also is a length that we look at when we talk about IVs. We want to make sure that we're assessing for latex allergy. A lot of supplies do have latex in them. We are seeing in hospitals now more latex allergies are so common that we do see most products are latex free, but it's always something good to think about. Is your tourniquet latex free? Are all of the supplies that you're gathering and that you need for that skill latex free? When we look at selecting a site for an IV, we want to make sure that we're not putting it in a client's extremity that's very edematous. And so if they maybe just have, previously had a blood clot or had surgery and that right arm is swollen, we wouldn't select that arm that's swollen. You don't want to use an arm that's just went through trauma. If the client's having a stroke and they're having weakness on one side of the body, you wouldn't put the IV on that side. When we talk about the client that's had a mastectomy, sometimes we've seen clients recently that'll have maybe a double mastectomy, and then you think, well, what am I supposed to do? Most of the time they only have had, or a lot of the time, they've only had breast cancer in one side. So then you need to ask the client which side did they have the lymph nodes removed from, because it's really related to your lymph nodes. And so whichever site they had the lymph nodes removed from would probably have been the cancerous side, and then you could use the other side. So it's not necessarily that we can't use the side that they've had a mastectomy in if it's been a prophylactic mastectomy. It's related to the lymph node involvement. And 9 times out of 10, these clients are going to know which arm you can and can't draw blood from or insert an IV in. If you've got a client on dialysis and they have a fistula, we would not want to use that arm. And then if there's any type of an infection, we also would pick a different site. This just shows you an example of the ideal veins for insertion. They're a little bit larger and they're less likely to have quite as many valves, which can cause us trouble when we insert. When we look at where we're going to pick for a site, you want to stay away from sites of the body that are going to bend. And so an example of this would be the arm, the antecubital at the elbow. That is constantly bending, and so that's not a preferred #1 site to try. You also want to think about what hand they right or are dominant with. And so if they're right-handed, try to get it in the left side, because it is still painful to have an IV in, and every time that they move that arm, they may have some pain. So it'll just be more comfortable for the client if you use the opposite extremity. When we look at let's see on this slide, when we look at the other puncture sites, it's also important to remember that when you first start an IV, you want to probably go more towards the hand. You can't, if an IV infiltrates or if you are unsuccessful with your first attempt, you can't go distal. So for example, if my client was right-handed and I decided I was going to try on their left side and I just didn't see much, I would want to start at the hand, because if I use a vein in the hand and it becomes infiltrated, or if I'm unsuccessful, I can move up to the forearm. And then if I'm unsuccessful with the forearm, I can move up to the antecubital as a last result. However, if you are inserting on the arm and it becomes infiltrated or you're unsuccessful, you cannot move back down to the hand. So you always need to be moving towards the body. You can't go back down and go more distal to the site if you have an infiltration or if you have an unsuccessful start. So just gives you more opportunities to gain IV access. We want to know the precautions for IV lines, and so we talked already that you're going to clean very good, and you're going to learn that in lab next week about how to properly prepare the arm for IV insertion, and this is to prevent any type of an infection. We also have talked about that the blood or the medication that you give is going to very rapidly go into circulation, so we want to make sure that they have been assessed for allergies and that we have the correct client, the correct medication, the correct dose before we administer it. We can cause that fluid overload, especially clients with CHF or things like that, so we want to make sure that we're not giving the fluids too fast and we're following the prescriber's orders. A client also might have a mainline infusion running of maybe they've got normal saline with potassium, and maybe now you're going to give a medication IV. You need to look up that medication and make sure that it's not only compatible with the lactated ringers or the normal saline, but you also need to make sure that it's compatible with the additive to the IV solution. So is it compatible with the potassium that's infusing? And that cannot be stressed of more importance, that you need to ensure that everything you're administering is compatible. We've got some definite complications that can occur with IVs, and this is coming directly from your ATI book now. And so I'm in that Fundamentals of Nursing book, 9th edition, page 292. So we know what an infection is, and these clients can receive an infection two ways with an IV: if we didn't properly prep the site, or if we did not properly prepare our medications and prepare our hub before administration. And so what we would often see if a client had an infection from that IV site is a systemic reaction. And so they may have a fever, they may just not feel well, they may have chills, and then you may have redness and swelling as well at that IV site. We can prevent this by making sure that we're properly preparing our site, we're following protocol. We're going to talk a little bit more later in this presentation about how we replace IV fluids, but you'll need to know your facility policy. And so most of the time, if your client isn't receiving a fluid at a rapid enough pace that they would use an entire bag in 24 hours, at 24 hours, you need to recognize that that bag's been open for 24 hours. The chance of microorganisms growing are greater, and so we would take that bag, throw it away, and you would start a new bag. We also look at tubing, primary and secondary tubing, and we're going to talk about what that is. But you need to know your policy as well for that tubing. And so oftentimes we'll replace tubing every 24 to sometimes 72 hours in practice. It just depends on your policy. So you've got to know how long your tubing's been up, and if that tubing's been used on that client for more than whatever your policy says, you're going to get new tubing. All of this is to decrease the chance that microorganisms are present and could cause some type of an infection. We also only keep IV sites for a certain amount of time, and so unless your client, is a really hard stick, or anesthesia or the medical doctor have certain other orders, and that if that IV's been in there for 3 days, that IV gets taken out and you put in a new IV. Most of the time, if it's not infiltrated, you do want to make sure that you get your second site in before you pull out the cannula from the first site, just in case you couldn't get it in and you needed to give medications in an emergency situation. But when you hit that 72-hour mark, you need to be thinking about getting a new IV site into that client. You want to change that dressing if it does become wet or soiled, because that can also be a place where infection can enter. And then anytime that you are inserting an IV on the client, you're going to date and time your dressing to clarify what time the IV was inserted into the skin. You'll document that in the electronic medical record. And then you're also going to label your tubing, and you're going to label your IV bag. And all of these labels will serve to help the next nurse that comes on shift, or the nurse in a couple of days, to understand if it's time to change the tubing or the bag yet. Another complication would be infiltration. Easiest way to remember infiltration is this would occur if that cannula sometimes somehow wiggles out of the vein. It also might occur if the needle went, when the nurse was inserting the IV, if that needle went through the vein, and then when the fluids are hung, those fluids might be coming outside of the vein. And so either the cannula came and worked its way out, or there was a hole in the vein through the vein, and so there's fluid in these interstitial spaces. And so what we want to do to make sure that this doesn't occur is secure that catheter after it's inserted so that it can't wiggle out of the vein. We want to make sure that we are selecting the correct site. That will help to reduce the risks of an infiltration. And you want to make sure that before you administer any medication or fluid, if they have a saline lock in place, that you are flushing it before you just give the medication or start fluids, because a lot of times cannulas that are saline locked will have a higher rate of becoming infiltrated or coming out of the vein. So what would we see? If you tried to give fluids to a client and that cannula was not in the vein, you would often see pale skin. You would see edema. It would be cool because all of that fluid is just collecting under the skin. We also often will have a hard time either pushing the fluids manually, or the pump will tell you that there's an occlusion. If you're using gravity, your fluids simply just might not be flowing. And so your first thing, if fluids aren't flowing freely via gravity, or if you're pushing it and there's resistance, is to think about, is that saline lock or is that cannula in the correct spot? Is it in the vein? If you noticed and identified that there was an infiltration, then what you would need to do is stop that infusion. You'd want to make sure and pull out that catheter, and you'd elevate the extremity. We look at phlebitis or thrombophlebitis. So phlebitis is when there's an inflammation present in the vein, and oftentimes we'll see this occurring from medication that's given into that site. And then if a clot forms, that's when we go to phlebitis or thrombophlebitis. And so the most important way we can prevent this is by rotating those IV sites, making sure that they're changed every 72 hours. And we avoid the legs and feet in the adult client because there's decreased circulation. And so it's not a preferred first choice site when we look at the adult client. We also want to make sure that we've got proper hand hygiene and that we are using that surgical asepsis when we insert that IV. Looking at signs of phlebitis and thrombophlebitis, oftentimes we'll see edema and there will be burning or pain at the site. We also will see that the IV fluids won't be infusing as easily, so we'll see that slower rate of infusion. What we want to do to treat this is to stop that infusion and remove the catheter. Oftentimes we'll also have warm compresses ordered a couple of times a day from the healthcare provider. A hematoma can occur if that vein is nicked and then it continues to bleed under the tissue, and so we'll have some bruising. Oftentimes we can prevent this by making sure that we lower our angle, which you'll learn next week in lab, as after we see that flashback, so that our needle does not pierce that back wall of the vein. And then we also can make sure to take that tourniquet off if we do happen to have an unsuccessful start, so that the pressure is relieved and we don't have an increased amount of bleeding from that tourniquet. We also want to make sure that after you discontinue an IV catheter, that you hold pressure for a couple of minutes, and then you also can elevate the extremity or hold longer if they are on any blood thinners such as heparin or Coumadin, Plavix, things like that. Signs and symptoms of a hematoma would be that bruising or ecchymosis to the site, and then oftentimes they may have a painful hard lump as well. So just make sure that you hold pressure after you take that IV cannula out. Circulatory overload would be when we insert or administer those fluids too rapidly, and so maybe we had our roller clamp or our drip rate incorrect, or some type of equipment malfunction happened. And so we want to be really careful, especially with those clients that have congestive heart failure, again, like we talked about earlier. And if you do have a client that for some reason you're administering fluids on via a gravity route, or that means without a pump regulating it, you really want to be frequently checking in on that client and ensuring that the fluids are going at the correct rate and that there's not anything wrong that's making them go more rapidly than what we want. If you have a pediatric client, usually it's standard of care that you check that bag every hour to make sure that they're not getting too much and that it's not going to compromise anything that might be occurring. So pediatrics or clients with CHF. What we would see if a client received too much fluid too fast, they would have increased blood pressure, kind of your classic signs of hypervolemia. They'd have distended jugular veins, they may have rapid breathing, they'd have oftentimes crackles or a cough and an increased heart rate. And so what you'd want to do is stop that infusion. You want to increase the head of the bed so that they make sure they have adequate oxygenation. And then oftentimes you would call and notify your healthcare provider, and they may order some type of a diuretic such as a Latex to help the client excrete some of that extra fluid. Electrolyte overload could occur if the order is administered incorrectly for an additive such as, again, I'll use potassium. If we gave that medication or that IV fluid containing that electrolyte too fast, or if we gave the wrong one or the wrong concentration. And so what we would do in that case is, grab a lab stick and make sure that we're assessing what the lab value is. You would, correct the wrong, and then make sure that you've got your drip rates sitting correctly from then on. So you just can't be too careful with IV fluids. A catheter embolism can occur if maybe when you are inserting the IV, you may see nurses pull that needle in and out of the cannula, and that is not correct practice. And so the reason is because when you push that needle back in through the catheter, if they're not in the vein all the way, they could push and break off a part of the plastic at the end of that, what I call the straw, just to help you remember. And so if a piece of that plastic cannula somehow gets dislodged or broken off, that's what will cause a catheter embolism. And so we want to make sure that we're not reinserting that needle or that stylet into the catheter. And standard of care when you remove an IV catheter is that you always are looking at the tip of the catheter to ensure that it is intact. What you would do if that tip of the catheter was not intact is immediately get a tourniquet and put it as high on the arm as you could, or where that IV was removed from, in hopes of trapping that piece of the cannula in that extremity, and then the client would need an x-ray, hoping to prevent it from going into the heart or lungs and causing some type of an embolus. An air embolism can occur if you don't prime your tubing and you give your client a whole bunch of air. Pumps are good and pumps will tell us if there's air, but if you did not get all the air out of the IV tubing past the cassette that goes into the pump, could be a way to give a client an air embolism. So it's really important to make sure that you've got all the air out of that IV tubing and that you're ready to go before you go ahead and start giving fluids to a client. What you would do if you did suspect that a client had an air embolus would be that you want to immediately clamp that tubing to prevent any more air from entering the circulation, and then you'd want to put them on their left side in Trendelenburg, which would be that head lower than the feet, and that's to try to trap that air into the right atrium, and so that it wouldn't also be pushed further into the system. And notify your healthcare provider. If a client has an air embolism, a lot of times they will have shortness of breath. They may have a bluing coloring or cyanosis to their skin. They may also have tachycardia and chest pain. And so usually you will see signs. I have seen this in practice, and those are all the signs that you do classically see when an air embolus does occur. So we've got two main types of IV fluids. We have crystalloids and colloids. And so when we look at crystalloids, this is what we pretty much use every day in practice. We don't use colloids a whole lot. So crystalloids are some type of a substance that's dissolved in fluid. And so a lot of times, like I said, we'll have sodium or chloride. Some solutions will also have some sugar or dextrose in them to help with that carbohydrate. And so some examples on the bottom of this would be your normal saline, 0.9%, half normal saline, 0.45%, lactated ringers are an example, and any of your dextrose fluids. We can further break crystalloids down into three different categories, and you need to know these three categories of IV fluids. You need to know which types of IV fluids are isotonic, which types are hypotonic, and you need to understand what's occurring at the cellular level with the fluid. So when we look at isotonic solutions, they're the same osmolarity as body fluids. What that means is that they don't increase the extracellular volume. They do not enter the cells and they don't cause a shift in the fluid. We often use these just to treat dehydration or to just treat and replenish electrolytes. Examples of isotonic are your 0.9% normal saline, 5% dextrose in water, or lactated ringers. A lot of times we'll see these used very commonly in practice. When we look at hypotonic, these are more diluted solutions. And so what that means is they have a lower osmolarity than the body fluid. This in turn then causes the movement of water into the cells. It causes osmosis, and so it increases the fluid in the cells. It rehydrates the cells. What we will often see is that we will use these administered slowly to prevent that from occurring too rapidly. That rehydration of cells can occur too rapidly. We'll see that clients that have maybe a low sodium level or a high sodium level or hypernatremia due to NPO will often have these. And so half normal saline or 0.45 normal saline or quarter normal saline, 0.225 normal saline are examples of hypotonic solutions. Hypertonic solutions are more concentrated, and so they've got that higher osmolality level than body fluids. So they cause the water to move outside of the cells and into the extracellular fluid. Examples of these would be D10W or D5NS. So again, that breakdown would be the D stands for dextrose, the 10 is the percent, W is water, and then in that bottom one, D5NS, again, D is dextrose, 5 is 5%, and then NS is the 0.9% normal saline. Colloids are large undissolved particles such as proteins or carbohydrates, and what we do is we use these to increase that oncotic pressure within the blood vessels and to help to pull any excess fluid from the cells or the surrounding tissues back into the blood. We often will have these called plasma volume expanders, and examples of these would be albumin, dextrin, and mannitol. This is an example of how colloids work to pull that fluid from the extracellular fluid or from those blue boxes, from that interstitial area, the tan area, and it pulls it back into the blood. Lots of safety precautions when we look at IVs. We want to make sure that we're checking the order, we're following those 6 rights, and we have at least 3 checks before we begin any infusion. Second point is that we want to make sure that the outer wrapping of the IV fluid is intact. There's no punctures, there's no tears, and there's been no compromise that has occurred. We want to check the manufacturer's expiration date. We want to make sure that if it is expired, we'll get a different bag. If we looked at the bag and we're looking at number 4, so if we remove the bag from the outer wrapper and we would see a puncture site or we would see that there was some fluid that had leaked out, we would want to make sure and get a new bag as well. If you look at the fluid and there's any type of discoloration or if there's any particles floating in the fluid, we would never want to administer that. An example would be that some IV fluids are a different color. There's what we refer to in healthcare as a banana bag, and there is a yellow color to that fluid. And so if you didn't know that, you would want to question, why am I administering a fluid that's yellow? But if you knew that a normal saline bottle wasn't supposed to be yellow and it was discolored or green, you would want to always get a different container of fluid. And then we want to make sure that when you're starting that IV fluid, whatever it may be, that since you're the person that starts it, you know when it was spiked, you label that fluid, because we know that those fluids can only be hanging most of the time per facility policy 24 hours, so that gets replaced in 24 hours in the case that it's not infusing rapidly enough to require it to be replaced before that. And then we also would label that tubing as well. So let's talk a little bit about IV tubing. We've got a couple of different sets, and so we have a primary set, and so your primary set is this long straight one here. This is always going to go to your primary infusion. So this is going to go to your normal saline, it's going to go to your lactated ringers, it's going to go to your half normal saline. It's a longer extension of tubing so that the client can move and have some freedom. When we look at primary tubing, it also has ports here or hubs where we can inject medication. So if the client is getting, let's use for example morphine sulfate for pain, and we're pushing morphine, we'd have to make sure that morphine was compatible with the solution hanging. Let's pretend that it's lactated ringers. I've looked it up and I've reassured that lactated ringers are compatible with morphine sulfate. We would use this port here then to attach our syringe containing the morphine, and so you would give that then through some of these ports. When we look at secondary tubing is often what we use for those antibiotics that are ordered every 6 or every 8 hours. We use secondary tubing if they're going to receive a one-time run of maybe potassium or something like that. It's not as long of a tubing because the tubing only goes to this highest port on the primary tubing. There is a push clamp, oftentimes a manual push clamp, and then also a roller clamp most of the times we see. Both sets of tubing have this drip chamber where you could count your drips if you're doing a manual or a gravity drip rate, and you also will still see the drips occurring in this chamber if you have it on a pump. Here's an example of what the roller clamp looks like, and we do most oftentimes, it's a white roller clamp that we see, and this clamp is also most of the time present on this secondary tubing as well. Okay, so when we look at primary tubing, again, we've got that insertion spike, and that insertion spike is it has a cap on it, and that's what you push into the main bag of IV fluid so that the fluid can come into the tubing. That drip chamber is where we count the drips. Most of the time, our drip rate for IV tubing is 10 to 20 milliliters an hour, and then sometimes you'll have a drop factor of 60. That's known as your micro drip rate. And so a lot of times if you have pediatrics or some type of a really special critical care setting type of a fluid, you would use a 60 drops per mil micro drip tubing. But otherwise, most of the time in common practice, we use a macro drip, which is 10 to 20 drops per milliliter, and it will tell you that right on the outside of your bag. It's not something that you're required to know. When you grab your bag of IV tubing, it'll tell you what the drip rate is. We will use this a lot this semester in math. If we look at maybe a provider ordered so many milligrams, the pharmacy gives you a solution that has 20 milligrams per milliliter, what would you set your drip rate to if you were doing a manual infusion? And so you'll definitely need to know your drip rate for a lot of the calculations, but the questions that we have will always tell you what your drip rate is. So again, secondary is shorter. We often use this for those medications that are needed intermittently, such as antibiotics. And they also have that spike so that we can puncture and get into that medication bag. And we often will also call these piggyback sets because they're in addition to that primary tubing. We do want to make sure that before we would connect any tubing to the client that we purge out all of that air. And so this is just an alert to make sure that you understand just how important that step is. This slide shows us 2 different types of pumps. Most of the time in practice we have a pump similar to the top pump. Most locations now have smart pumps where we can select the fluid, we select the if there's a medication that we're infusing, we select the concentration, and that takes the guesswork out of it to make sure that we are giving the correct amount of fluid. The bottom is an example of a syringe pump, and this is what we use we use this in the nursery all the time when we give amp and gent for a baby that's got an infection. So it's used for a smaller amount of fluid, and so what you can do is ensure more accuracy, and the medication comes in a syringe like this, and then the syringe goes into this device, and we would give that with a syringe pump. Again, the third bullet down is that you can give fluids without a pump, and that would be when we talk about a manual or a gravity flow. And when fluids are infusing by gravity, that's when it's really important that you would actually be counting the drips in your drip rate to make sure that you're giving the correct amount of fluid. Okay, here's an example of pumps, and when we look at pumps, they are those electronic devices that use pressure instead of gravity to push the fluids into the vein. They do have a special type of tubing, and the tubing comes with a special cassette which goes into this area of the IV pump, and that's what allows it to regulate the amount of fluid that's given. The pumps come with alarms, and so the alarms will beep if there's an occlusion, whether it be that you forgot to open up a clamp up at the top part, or if it is maybe it's an infiltration that's occurred in the client, and it'll pump and tell you that it's not overcoming the pressure. And so there's different things that will also alert you if there's something wrong. If there is air that maybe you set the volume too high and you set it to deliver more air or more fluid than what's in the bag, and then it'll insert all that fluid, but then when it starts to have air in the tube and air gets into this chamber, it will alarm and it will not allow you to instill air into the client. So it'll alarm and say that there's air present. So pretty cool technology that we have with the infusion pumps. They do regulate the flow better than the drip controllers because we can easily have that pump that would tell us that it's having to work too hard. There are pumps, the pumps are able to overcome a little bit of pressure, and so sometimes if a cannula is up against a vein or if the arm is bent, it will be able to overcome some pressure, and sometimes your gravity fluids won't be able to do that. Oftentimes also that third bullet pump tells us that they have the smart pumps, and so those will kind of do some dose calculation for you. The whole goal is to reduce those medication errors. They're not without danger because they can infuse fluids causing an infiltration into the location. So just because you have a pump doesn't mean that it's not going to instill fluid into that extra vascular fluid or that extravascular tissue, and so you need to make sure, always be checking your client to make sure that there's not edema or pain and that there's not an infiltration occurring. We also can program that pump incorrectly, and so if we are supposed to be infusing the fluids at 125 milliliters per hour and we are hanging a 500 milliliter bag, for example, and we are busy and we accidentally push in 500 milliliters per hour, you're going to give that client that whole bag of fluid in 1 hour instead of, just 125 milliliters per hour. So we really have to be careful when we program these pumps. This is just a little bit more about the syringe pump. Oftentimes they can run on battery for some amount of time, just like an IV pump could, and they will oftentimes work if we need something more accurate or slower, a little bit more sensitive, such as a pediatric or a neonatal dose. When we look at using gravity or a manual flow, we need to make sure that there's a benefit to this, and the benefit is that it's low cost. You can do it, in an ambulance or in a care area setting without expensive equipment. There's some things that definitely affect the rate that your fluid is going in, and so if you would raise up the height of the bag, it will go in faster. If you would lower the height of the bag, it would go in slower. If you had a fluid that was really viscous, really thick dextrose type solution, that would go in slower. If you had a solution that was really, really thin or a lower viscosity, that'll go in faster. We also need to think about the size of the IV catheter. If you had a 24 or a really small IV catheter, that's just not going to be able to infuse by gravity as fast as if you had, for example, a 16 gauge and you had your roller clamp wide open and your bag up really, really high in the air, as high as your pole would go. That would instill a lot more fluid than a 24 gauge catheter that's not up as high. So there's definitely things that affect it, and that's why we need to be counting our drip rate, because our drip rate is what affects that. When we look at gravity, we've got our drops per minute, and that's what you literally would count to make sure that you are infusing it at the correct rate. You would want to make sure and use a A time tape will help us to look at where the fluid should be at a certain given time, and it's our double check that we've counted our drops correctly per minute and that our fluids aren't infusing too fast or too slow. There's a high risk that comes with gravity fluids, and that's just that, you know, if a client themselves opens that roller clamp, they can easily adjust the rate of the fluids. And so the nurse needs to really be cautious and needs to be back into the room checking on those fluids frequently to make sure that nothing has happened. We do want to make sure that we're labeling the bags of IV fluid as well as the IV tubing. And so we want to do that to not only make sure that we're giving it to the right client, but also to make sure that we're getting it changed on time so that we can't have any increased risk of infection occurring within our client. This is an example of what a label may look like for IV fluids. And so it goes on the client's bag of fluid and it tells you the type of solution. And so an example would be maybe they had normal saline hanging. You also would note on here what the order is for the infusion, what the flow rate is supposed to be. If anything was added to the bag of fluids, so for this example we have ampicillin 500 milligrams. So if anything was added, that has to be noted on the outside of the bag. You also want to note on the outside of the bag the date and the time that it was spiked, because we know that we only usually will use that for 24 hours depending on facility policy. And then also the nurse that prepared the IV fluid. So if you did add anything to it, you would initial that you were the nurse that injected that 500 milligrams of ampicillin. Most of the time we have a nursing supervisor or a pharmacist that prepares fluids, but we are a rural state and there are rural hospitals where nurses are adding their own medications to their IV fluids, and so it's your responsibility to clearly note how much you added and then the date and the time that you added it along with your initials. When we look at labeling IV tubing, you again need to know your facility policy. Usually though, tubing is changed every 24 to 72 hours depending on the facility. And so what would happen then is you need to be always looking at your label of your tubing when you initially go in to assess your client. You've got to know when that tubing was hung, because if then you need to change it, part of your time management would be grabbing that when you're out of the room and doing it with another nursing type of a skill that you would already be in the room doing. If you are the first person inserting an IV and hanging fluids and you're the first one that gets to put a label on that tubing, you are going to want to make sure and label the date and time that you initially expelled the air from the tubing. You are going to also write when it expires and then your initials. Usually these are a bright color so that it's easily identified. If you walk into a room and there's no label on the IV tubing, there's a couple of things you can do. If the client just was admitted last night, it's pretty easy to know that your tubing hasn't been hanging very long. But if your client's been there for a couple of days and maybe they're going on their 4th, 5th day, you really do need to replace that tubing and you need to hang new tubing, because you don't know if it's been there 5 days. And if that client gets an infection, you missed an opportunity to prevent that infection. So it's really important that you're checking for those stickers, you're noting when they expire, and if they're not labeled, you also need to take initiative and re-hang new tubing, because we could prevent an infection that way. All right, I hope this PowerPoint helps you with your assignment this week. You have this first worksheet next week and your worksheet next week in week 3, worksheet number 1, catheters and IV fluids. This PowerPoint will also help you with that, and it will help you with your math quiz this week. So good luck, and let me know if you have any questions at all.